what's also always worth reminding ourselves is that we place equity in the center of that model, and we do it so that we are expressly building in equity into our improvements, into our measures and data, and also sometimes we might have an improvement for one part of our population that's actually a disadvantage for another part of our population. So really kind of looking at that carefully. So with that in mind, today is about digital platforms for health. And I wanted to start by just giving us a bit of a definition, because this is an area where there's a lot of myth and confusion. And digital platforms for health, particularly now that we've come out of a worldwide pandemic, are sometimes seen as just video consults. And so the first thing I wanted to do was really frame it in a much broader sense. Technology, of course, is everywhere, and it is not only about it being a platform to deliver a health service, so that might be a telephone, or it might be a secure email, or it could be, a video consult, but it is also digital information, either to ourselves, so that might be, information in health pathways, or information in databases, or either practice management systems or other kinds of systems. It might be tech around results. Slowly there's AI being used for inbox management. And it could also be information or data for patients. So increasingly, there is a growing movement of patients having their own patient portals, having access to their own monitoring information, having access to advice around that, and being able to access care using technology. So it's a big, broad spectrum of applications in healthcare. And it is a spectrum that is changing all the time. And we know this only too well after COVID, where general practice actually got very good at taking on new technology, learning it quickly, and then applying it. This idea of the breadth of technology is well described here in a slide that those of you who have attended Wānanga 1 and 2 would have seen before. So it's the patient journey um, with a technology overlay. And it really talks of the person that we are supporting, or the community or whānau that we're supporting, being at the center of that journey, with their own health information and access to health monitoring. And that might be through some sort of a smart device, but it could also be by going to have your blood pressure taken at your pharmacy. So it could be community services that are supporting that concept. And that person may have some sort of a coordinator or key worker or kaiawhina, depending on their needs, walking that journey with them. And I've introduced the idea of access, and we'll talk more about access, which is enabled by choice, essentially. So access could still be telephone, or it could still be walk-in if that's what's working for that patient and that service provider, but indeed access via patient portals. And when we have a look at the analysis, you'll find, in fact, this is still aspirational. A lot of what's in this sort of diagram is aspirational. And then what this really shows is once somebody has accessed care, being able to choose the platform and possibly the service provider, and also the practice having processes and protocols in place such that we know who's the best person for this patient to see. So for example, a patient who has had some mental health needs might be best suited with a hip appointment straight away. They don't need a GP appointment first and then a hip appointment. And so having protocols in place, and technology would be a significant part of those protocols, to make sure that the right person gets in front of the right provider at the right time. You can see how the picture gets more complicated. And I'm going to just talk a little bit here and then give Carol a second to talk also to some of this. We didn't say this, those of you who haven't seen Carol and I present before, we both worked in general practice during the COVID years together. There are some other people online who were with us at the time. And so it's what we can do is talk from our experience, and I will also draw on some of the experiences across the country around use of platforms for digital health. This drawing is kind of complicated, but really what I'm trying to say here is that it's the same as what I was saying in the definitions of digital platforms. There are many different platforms to support multiple different patient needs. And if you think of those relative to workforce, so for example, who in your workforce are responding to manage my health appointment requests or manage my health messages. That may be GPs and or prescribers and or pharmacists. Who is looking at health analytics? So, for example, risk stratification data. Often that is nurse-led. Again, hips and health coaches can get very involved in that. For example, at Tikipunga, our pharmacist would run complex discharges that had been made in the last 7 days and have a look at those. And at the top of the tree, I've also put shared care. There's a high range of variability across the country in terms of shared care planning platforms where both secondary and primary and community services can see the same care plan. It is a fundamental part of complex care and whānau hauora-led care. So, if you haven't got a shared care platform, that kind of becomes a problem. Carol, I'm just going to give you a moment to talk a little bit about the work we did around bringing our PHO in Te Tai Tokoro, Mahitahi, in to teach nurses around data and risk stratification. I wondered if you wanted to just share with us for 5 minutes or a few minutes what, that experience from your point of view. And you're on mute.
Can you just remind me again, Mel, what that was about? We didn't previously discuss that. You're on mute, Mel.
You'll remember we used to have a weekly meeting to look at data like patients overdue their DARs or patients who had high needs but never came in, actually proactive care based on data and just talking about how nurses responded to that.
Okay, so weekly we would have a meeting where we would use Kanban, and it was an ability to see where we were and what we, as a team, who was doing what, and it was a really good way of seeing the data and putting the data into action and meeting those needs of those clients that, like Mel was saying, hadn't had their updated, say, for example, their annual diabetic review. And so what we did is we would have a champion role, and then they would be able to report back at those meetings and work with a team, like a healthcare assistant and the pharmacist, and we'd work with a team. And it was a way that we were able to monitor how we were doing. It was a way to see that it wasn't quite so overwhelming, to see that these patients were being seen, and also a way to see the ones that weren't being seen, and to then come up with a plan to reach our hard, our people that weren't getting seen. So we were able to monitor each week, and each person had a different role, and each person was able to report back on what they had done and who they had seen and who still needed to be seen. So a really good way of keeping on top.
Yeah, and I guess the point we're making here, and that's what we were talking about last week, is that if one's just responding to urgent unplanned care, then you're going to miss, particularly for a patient who is not actually requesting access but has high needs, they would inevitably come in very acutely or indeed not at all. So it's about scheduling protected time for the right workforce to look at data and then make a proactive plan. And some of what Carol was talking about is using that team in a multidisciplinary team way. So it might be nurse or GP led, and then there would be a plan around a healthcare assistant might see that patient before they came in to see the nurse, etc. So kind of building an MDT style plan based on using data, and that data, of course, is relative to technology. Okay, so just building on the picture, many of you will know this, in the early 2 years plan Te Pai Tata, there is a focus on digital services and an intent to scale and adapt. And I think that's exactly right. That is where we are. We know that the healthcare homes, who have been around, many of them for 6 to 8 years now, have been using telephone triage very consistently, and that is a viable digital platform for delivering health. It's been successfully implemented across 20 to 30% of the country's general practice. So, that is an at-scale implementation, but of course there's still 70% to be had. So we are at that point where we really need to scale the model. And we also know that one of the things that's holding us back is the lack of interoperability, and I'll talk a little bit more about that. The fragmentation might be another way of saying it, of multiple little different bits and pieces in general practice that don't kind of glue together. Access, digital access, and what does that actually mean? And we'll talk about that a bit more too. So I'm going to go and share some of the results we've had from a survey that we put out to general practice in the last few months, Collaborative Aotearoa generated survey. And I'm going to use them, as I say, as a kind of place, a springboard for us to then talk about some of the ways in which digital health has been delivered across the country, and some of the breadth that exists, because there is actually quite a lot of richness there. And just give you a few little kind of orientating around the survey itself. So we did quite a lot of research around uptake of particularly things like patient portals and telephone triage prior to COVID. And the healthcare homes that had implemented prior to COVID were doing well. And we were interested to know what that looked like after COVID. Anecdotally, we knew that there were practices who previously had had things like clinical triage for same-day requests as a consistent offering and were doing well with proactive care, scheduling time, protected time, but the additional demands of COVID had kind of pushed them back into only just managing same day, or possibly not even managing same day. So we were interested to know how much of that exists and what can we do to support moving forward again. I'll just go back because I missed out on the point. So the survey has been open since December. We've had 109 responses, which is not a ginormous amount, but it's enough to kind of give us a sense of what's going on. And it does confirm what we've seen anecdotally, because we visit practices and PHOs all the time. So as I say, this may not be everybody's experience, but it's useful to get us to think. What am I doing? What could I be doing? What are my barriers? And really that's the intent of going through this data over the next sort of 15 minutes. So you can see a little smattering of where we got our responses from. And I'm going to start with the key findings and then go into them, and I will give Carol a chance to give us, some of her observations around this as well. So as I say, some of this is not a surprise. For me, the biggest surprise is actually how much more there is still to do, or the size of the opportunity. So phone and secure messages are the most common digital platform. And then there is telemonitoring and shared medical appointments and some other things that are sort of coming along after COVID. And one of the things we have seen is a real breadth of roles, which is interesting and encouraging, and I'll show you that data. Huge opportunity still is patient portal, and we talk a little bit more about the barriers to that. And indeed, then I finish up with kind of planning and barriers and what general practice might do next to continue that scale adoption. And kind of what I said right at the beginning, there is a breadth, there are multiple choices of what a digital platform might be. It could be a telephone, it could be a mobile, it could be a video, it could be a secure message, it could be, there are many different things, telemonitoring. What we do know is that most of the implementation, which is actually still quite low, it's kind of under 50%, is either email or telephone. And okay, that's interesting. And it's interesting to ask ourselves why that's working, and also why is that all it is? Or is that okay, if it's working and, we don't have to, it makes me think of the lean words, make it, only do an improvement if it's going to be better. If it isn't going to be better, don't do it. So, we don't have to do virtual consultations for the sake of it. And it makes us also think, why would we do them? And when are they appropriate and when are they not appropriate? So I think it's worth kind of unpacking, what is it? Someone's not on mute. I'll just have a little look. Who's Carol?
I fixed it, Mel, muted everyone.
I'm still on. Very good. Okay, I'll carry on. Thank you. Right. Now, interesting. One of the things we knew pre-COVID was certainly for healthcare homes, a big chunk of delivering services on some sort of a digital platform was telephone triage. And it was being done by mainly GPs, some nurses, and also nurse prescribers increasingly. And we know that during COVID, triage, particularly for a healthcare home, was a really important part of managing same-day demand, even when most of our consultations were virtual and or our workforce was changing. The ability to have a single list of patients who need services today made a huge difference, and that list can be supported remotely. What we've seen over those 2 to 3 years is a real growth of who in the workforce is using a digital platform. And as we see that growth, so here's some cool data: practice nurses, nurse prescribers, HIPs, and health coaches, the type of platform changes. So I think it's helpful to think, for example, that the telephone, which we use to triage, in other words, do I or do I not need to see you today, and or is it a quick service delivery? That sounds fine for that kind of process, screening. The telephone may not be so good for a mental health consultation, for example. And as HIPs or health coaches or pharmacists are offering different kinds of services or different parts of the care, so we see the use of other kinds of technologies, in particular video. And I think it's helpful to think of it again using lean language. What's the value that the platform brings? It's not a replacement. It can sometimes bring a value that we couldn't have in person. Carol, it might be a good time to think about, I don't know if you want to talk about HIPs and health coaches or supporting younger children with anxiety during COVID, that sort of thing online, whether you've got any stories to share.
Yeah, I was just, as you were speaking, Mel, I was just saying that the benefits of this, of using digital technology is, you know, access is definitely one of the huge benefits as far as particularly when we've got remote GPs. We know we can run nurse-led clinics and have GP access for some of those more remote areas with digital health. And so the benefits of that, definitely access and being efficient. You know, like we're able to work remotely, we're able to do repeat prescriptions remotely, and it's not just, you know, it's that older people are really getting very good at using digital technology and are very high uptakers of that platform, particularly Manage My Health. And it's a way to run a little bit more efficiently within the practice, and of course remotely, which we're having to do more and more so that we've got those staff. As far as our, we've had situations where we've had young people needing access with, you know, being anxiety and things like that, and we've been able to have our health coach go online, and you know, they get an immediate response, which is necessary. I have a situation at the moment with a young boy who you know what needs to see a therapist, and it's 8 months to book in. But if they could use an online portal, it makes it so much better and more efficient. And the other thing is that young people aren't engaging very well with GP practices from data, and we find that, you know, young people particularly would engage a lot more using digital platforms, and it just gives everybody another option and a way to access care quickly and efficiently. So yes.
Thank you, Carol. I'm noticing I've got lots more slides, so I'm going to push on because we've got lots of data and we've got 20 more minutes. Okay, so here you are. You can see that the data is telling the story of a growth of what do we use a platform for, and general practice, and as I say, COVID definitely accelerated this, has got much better at using digital platforms for workforce education, for internal meetings, for multidisciplinary team meetings. For example, Te Tai Tokara has been actively supporting multidisciplinary meetings with specialists in the hospital and teams in general practice for 3 or 4 years now. That's amazing. It makes it possible to talk about patients that maybe have been, bouncing around the health system, or a referral was made and that wasn't accepted. It gives the team a chance to paint a picture. And in the Te Tai Tokoro multidisciplinary team meetings that went on online during COVID, there was also a Ministry of Social Development person, as well as mental health providers and specialists and general practice. So it was a really great example of being able to make decisions for that patient based on that conversation there and then, as opposed to kind of multiple referrals snaking their way through a siloed health system. So you can start seeing a breadth of use of it. And no surprise that when we look at portals, however, and this is across the whole of general practice, this is not just healthcare homes, there is still a real low uptake. And I'm just going to kind of move on to the next slide to talk a bit about that. And I think what's worth thinking or reminding ourselves is that a patient portal can do many things. So it's possible to be able to book appointments, look at your results, look at your secure messages, etc. Right? And if a practice is well geared up for this, and this is, part of one of the challenges, then it's incredibly efficient from the patient and the practice's point of view. But it takes time to set standardized processes, to set standards for your patients. So, just picking out one little example, patients who call general practice to say, did my results come back? If we, consistently say to those patients, we will not tell you normal results, we're not going to call you for those, but you can see them in Manage My Health. They would be filed there because they're normal. And if you did need to know something, of course, a clinician or a member of your care team would be getting hold of you, so that they learn that's where it is, that's where I can see what's going on, I can book appointments from there. We also know, for example, during COVID, that lots of practices who were using Portal for appointments switched them off, and it was because there was a huge pressure around screening who came into a practice, and that becomes really hard when you've got phones and messages and walk-ins. As that picture changes, it's not really gone away, but it's changed. It is actually really important to re-engage with being able to make it possible for patients to manage appointments online. And today we don't have the time to go into it in detail, but to work through some of the process issues, because I know there are quite a few, like have they got the right appointment, and should they be seeing that person or someone else? So there are things to work through there. We did look a bit about barriers. So the last part of my thinking is, what's holding us back? Because what we have learned is there is a lot of opportunity for innovation here. It makes me think of something that Dr. Andrew Miller from Bushroad would say. Bushroad has been a healthcare home for a long time, as many of you have, and they have, significant clinical triage every day, significant Manage My Health requests, lots of things that come in through the portal. If the portal and Manage My Health were not switched on, those people would be coming in. So that's the reality of it, So some practices will see it as extra work. It is the work that exists. It's just a different way of doing it. So some of these things, like booking appointments and being able to talk to members of the care team, are still really significant challenges. And the next few slides just thinks through why. And one of the things that we have seen, and as I say, this really is backed up by what we see in general practice, is that actually there is not much capacity, is perhaps a good word, and maybe even knowledge inside of general practice today to specifically strategize and plan digital uptake. Often it's the business of perhaps the practice manager. What we see working best when we see practices that have change teams, that have clinicians and practice managers and admin people and other members of care teams, perhaps mental health workers in those change teams, specifically looking at what are our digital aims, what does our patient population need, do we have a strategy? You can see in this data, most practices would not really have that in place. And even things like training, and it's a good time to remind you that Collaborative Aotearoa does have a telehealth module online. If you guys don't know where it is, we can email that back out to you. We do see clinicians across the entire hospital system going on it all of the time, and it has really great learning material around clinical safety, patient need, preparing for an online consult, all sorts of things. So it really helps the service provider prepare and learn for that platform. We also know, and on the right-hand side, this is real basics in some senses, little things, the administration processes that sit behind digital platforms, setting up codes. So, I think this is a kind of a little picture or window into the end-to-end process in general practice, where if a patient does end up with a virtual consult, does that result in the right invoice at the right place? And for some practices, not so much. It's still an ad hoc process as opposed to a standardized process. I think that's a good way of putting it. And we do know that not many general practices even refer to digital health strategies or guidelines. So I guess what we're hearing here is that it's not really built into a general practices planning yet. This is maybe an opportunity for PHOs as well. But for the benefit of you, those who do access guidelines, there's a little list here of where that comes from. And what that also shows us is there is actually a wealth of information out there that is available, and it's something that we can work on based on the interest that we get from general practice and from our PHOs, is to consolidate where all that information is. But there are good guidelines around the medico-legal implications of virtual consultations and clinical triage. I think the good news is that this work has been going on for at least 8 years, and a lot of those early problems have been resolved in terms of guidelines and medico-legal kind of frameworks. And even Manage My Health and the Ministry of Health have put much more formal information up on those sort of things. Barriers, and I'm thinking, Carol, I've been doing an awful lot of talking. I'm going to pick up one as an example for myself, whilst I let Carol just have a little think about, the experience in general practice from a change point of view. But one thing I thought I'd just pick up on, quite often a barrier to supporting Maori or Pacifica to use digital health platforms is lack of data or lack of phones and or tablets. And there has been a lot of really good work across the country to kind of really work through that. And instead of taking okay, well, that means that Maori aren't going to really be able to use digital platforms well, taking a different attitude to that and thinking, how can I use this as an opportunity? And a piece of work that was done by a Pacifica organization in Auckland a year ago is something I'd just like to refer to, because I thought it was a really, really great piece of work that kind of leans into that whole issue. And what that particular organization did was build a project where they actually got some funding for some tablets and trained up younger people, kind of kaiawhina training, but really around the use of portals to do things like book appointments, look at your care plan, look at your results, talk to your care team. And they made those people available in community places where we spiritually or as a community come together. So churches, playgrounds, nurseries, that sort of thing, as champions, digital champions, connecting with that community, that their own whānau. And by doing that, being able to sit down together with each individual in that community, whether that was perhaps an older person who was feeling kind of a bit confused by the tech platform, or somebody who didn't understand how to, create a Gmail account, whatever it might be, younger people who were from their community sitting together with them going, okay, let's do this together. And that was made available in a kind of shared appointment style offer. So every Tuesday in the church, there would be 2 digital champions, and anybody from that community could come and pop in and say, hey, can you help me manage, can you help me log into my Manage My Health? I want to see if my results have come back, or I need an appointment with the doctor. So it is a really great example of a kind of focused, targeted piece of work using technology to support a community that maybe in the past would not have necessarily benefited from that technology implementation. It's also a good example of getting over the barrier of data, as in mobile data, because those services were offered in a kind of community church hall or in a marae where there was already internet and a tablet was being provided. So it kind of got over all of those things, but also used the community cohesion, community support to help access or connect with one's healthcare team. Carol, do you want to just think a little bit about the barriers? And I'm thinking particularly even GPs who maybe were very concerned about using video consults or platforms for health.
When, one of the things I was looking at there is that patients' preference for in-person consultation, and that can also be GP's preference for inpatient consultation, and it's because we do the same that we've always done. So change, you know, is about trust and making sure that it works and having the platforms well set up, and education for the GPs as well as our patients, and how effective they can be and efficient. And I think that any change has to come with, you know, like good platforms, good education, and an element of building trust. The other thing that can be so beneficial with digital health is that the whānau can get involved, and sometimes that might be, you know, mums in Wellington and daughters in Auckland and at university, and they can get on the same portal and have that consultation together, and bringing the whānau around and creating much more continuity of care and open notes. And a lot of that comes in with patient confidentiality and making sure that those things have been addressed prior to bringing other people into those portals. But people are really generally, once they learn and get used to it, uptake it really well and see the benefits of it. But yeah, I think it's a lot of it's education and having the right systems in place prior to starting, and encouraging our GPs to look at different ways of connecting with their patients.
Yeah, I mean, just picking up on, because the availability of equipment is low in this graph, but I think it's interesting, just based on experience and what I've seen in general practice. The ideal setup is to have 2 screens. Everything's, you know, camera and audio enabled. Every room works the same, and most general practice is not set up like that. I've seen some general practices where there are a few consult rooms that have like 2 screens, but not every single one. Maybe there are some out there, and that would be amazing. In secondary care, having 2 screens for clinicians is really normal because our brains like to compare. So it's kind of a good way to work anyway. But certainly for digital consults, that's an ideal setup. And there is for sure a financial barrier there too, because for a general practice that doesn't have really modern Wi-Fi and video enabled computers, and I know when we were in general practice that was in fact not the case. We had to spend years getting ourselves to the, you know, modern world because we couldn't do it all at once. So it does take time, and it takes investment. That's right. Okay, so I have got just the last sort of 4 minutes to really think about change and how we go from where you are today to, you know, picking up on some of those future innovations and opportunities. The 3 Wānanga sessions have been so quick and it's been a real joy to share with you everything we've got. But certainly one of the things I felt is we need so much more time. So every single one of the subjects we've covered, we could spend way more time on. But I think it's worth just acknowledging that everybody we're talking to is already on a journey. Much of what we say you would have heard before. There's, you know, it's not rocket science. And indeed, whilst there are lots of things that we still haven't achieved, there is a lot that we have achieved. So we're on a journey, but we need to continue that journey. And particularly what I said about digital health at the beginning is that a level of adoption has already occurred. We're kind of at the let's scale it up stage. We're not at the very early beginnings. Sometimes at the let's scale it up stage is challenging. How do we make this normal integrated part of our business as opposed to something we do some of the time. Many of you who have taken on the ProSci training will have seen this before. It's just worth remembering those stages for change, and that awareness and desire are really come before knowledge and ability. And so what isn't successful is to write a nice manual and, you know, implement, put some consult rooms together with the right tech platforms and go, here you go, this is how you run a video consult, because nobody's going to do it. And that's because they don't know what they don't know. And even patients, you know, I think that patients prefer in-person consultations was particularly true because during COVID, a virtual consultation felt like a no. When a virtual consultation feels like a yes with value, well, that's different. But we have to deliver the value consistently, right? If it's consistently not valuable, then so why is it any better, you know, developing some desire for a platform that we all see value in as opposed to not, and then developing the knowledge and ability. And I am just going to throw in, because I am a lean practitioner and I always end up with lean, just chucking in a bit of the lean Kaizen fourth part of that domain. And the reason why I've put it here is that it's all very well to say these are all the wonderful things you could do, but I know that general practice has not got enough workforce to even do all the things we do today. And many people in general practice, when we talk about these opportunities, would say, when am I supposed to be doing this stuff? I'm on the back foot. And so I've introduced Lean and Kaizen just to remind us that really the essence of this improvement methodology is change for the good all the time, every single day, built into our daily habits. And today is not about lean, so don't have time to talk about exactly how we do that. But the idea is small incremental improvements built in every day, as opposed to, you know, 6-hour meetings talking about how are we going to change how we work. And I did want to just bring up the idea of identifying waste in general practice, because if we do not have enough time, the first thing we need to do is find some time to sit down and do some planning before we then move forward to try something new. Because what lean also teaches us is don't just grasp at straws, do good analysis, do good consultation, and then do something new and do it well. And so very often a place to start is to look at waste, because there is a lot of waste in general practice. A lot of it is duplicate working or poor access flow. So it kind of comes back to the digital platform. If you've got a patient making a phone call, being triaged by a nurse who then asks the GP to see them, who asks all the same questions, who then passes them on to a social worker. I'm kind of over, you know, embellishing my example. That is a lot of duplicate working. It'll probably involve a lot of waiting. There's so much waiting in general practice. There's quite a lot of bottlenecks in general practice. Only certain people know how to do certain things, or we only do certain things at certain times. We sign prescriptions at 4 o'clock, so everybody waits until 4 o'clock before the prescription is signed. That sort of thing. There is an opportunity to free up waste so that we can use our people at the right place in the right time, and indeed also give our people time for improvement, actual scheduled improvement time. That's right. I've got, yeah, we're on 45 minutes. So last couple of slides, I have already talked about this incremental change, plan, do, study, act cycle. Many of you have studied this. The idea is one person, one time, one video consult. How was that? Awful. Okay, why? Because the patient had no idea what was going on. Right, let's work on that. You know, so try, and don't leave it too long between plan, do, study, act cycles, right? We don't do one video consult in January and another one in April and go, we're not getting very far. So consistency, repeat, follow the process, gains traction over time in everything. This is why change teams is kind of useful. And so I'm finishing up on, you know, what is your plan? If you're in a general practice that is overrun, doesn't have enough GPs, has got way more complex patient demand, is, you know, struggling with the winter season, and that's probably most of you, what's the plan? There are some things you can do that would alleviate immediate pressures, both for your patients and for yourselves. And some of that is around access and flow in digital platforms, you know, like open up your portal. And that's kind of me and where we've got to. So before I'll just come off the karakia, I will just give us, we're actually 1 minute over, so just see maybe in chat if there's any burning questions. Yes, a point there about rural connectivity, absolutely. And that is slowly changing. I hear even in the Hokianga, satellite connections are kind of on the plan for the next year. Okay. I think then, without any further ado, I'm just going to say thank you very much for being with us. Absolutely amazing to spend another 45 minutes with you, 47 actually to be precise. Please contact us if there's any feedback, any questions, anything you think we could have done better. And thank you again. And I'll let Carol close us with our closing karakia.
Yes, so please, again, I just reiterate what Mel has said. If you did want to ask questions, we have run out of time, and just if you email them, we'll endeavour to get back to you as soon as possible. Okay. He karakia whakamutanga. Kia hora te marino, kia whakapapa, pounamu te moana, kia tere te karohirohi, e mua e tō huarahi. Okay, ka kite. Lovely to see you.
Everyone. Thank you. Have an awesome Thursday and Friday. Ka kite.